There's a great deal of interesting things that have happened at the university here and in informatics in Utah for many, many years. And I was tickled pink to see all the pictures posted on Facebook by Dean Siddig for the 50th anniversary. That was really remarkable. Not many institutions, I think, are anywhere near that in their scope of work. Let's see. Is this the right one?
You might just have to use the keyboard.
Okie dokie. No. So, you know, what I'd like to do is to really present kind of the 90,000-foot view of where we are, I think, in healthcare and how the application of healthcare IT mostly can help us. I'm going to not delve deeply into the story of how healthcare IT can hurt us, but share with you some opening remarks about how I feel we're motivated to address the problems in healthcare with IT. And again, not Coles to Newcastle, but highlight some of the dimensions of informatics that are applicable to this care transformation process that we're in. And specifically focus on what are the two things I love the most: clinical decision support and knowledge management, and the relationship to translational research and informatics. Talk a little bit about strategy and in-care transformation, and a very little bit and at a high level about technology infrastructures, and close with a review of some of the work done in the Clinical Decision Support Consortium. Oops. Oh, there we go. So in the U.S., these data have been around for a while, but I find them always to be so grounding. We have an incomplete knowledge of our patients. That is, the record is oftentimes incomplete. Paul Tang found four missing items on average in a clinic analysis. Lucian Leap found in the medical outcomes study 18% of medical errors are due to inadequate availability of patient information. And Medicare beneficiaries see anywhere from 1.3 to 13.8 different providers annually, and on average 6.4 different providers per year. And for my mom, what this meant was to go see all the siblings across the country in Maine and New York and Colorado and Oregon. She'd have to travel with her jacket of X-ray studies and a copy of the chart. A little bit back in the day, but I'd hazard to guess things would still be similar today. It strikes me that we're still struggling with how to translate new knowledge into practice in a facile manner. Certainly one has to be careful about what is actual new knowledge. If John Ioannidis at Stanford suggests that 90% of studies aren't really worth doing or remembering or using, you know, only 10% are true, and that there's this validation stage in discovering new knowledge. But what we do know, we should be sure, is translated into practice. And secondarily, I think we've not yet tapped the well at all to use practice-based experience. I'll distinguish evidence-based medicine or knowledge-based care, that which is driven by guidelines and protocols and rules and other inference mechanisms, from that care which might be derived from analysis of the local practice and its experience, and comparing the local practice to the rest of the hospital, the IDN, the region, or national norms. We need to accelerate the translation of new knowledge into operational clinical IT as soon as it is practicable to do so. And lastly, the clinical information needs problem. This confounds the data needs problem, the average record missing 4 critical items. We know that physicians in practice, ambulatory care, inpatient care, urban care settings, and rural care settings have information deficiencies. What is the right thing to do for this patient, diagnostically, therapeutically, by way of referral, and whatnot. And on average, more than one unanswered question per patient remains in each clinical encounter. So anyone remember who this guy is? I only have one gray-haired old man, well, I guess besides me, but who's this guy? Society reaps at this moment but a small fraction of the advantage of which current knowledge has the power to confer. This is Abraham Flexner in the 1910 report. He was examining the quality of medical education across the country, found more than 50% of hospitals or medical schools to be kind of, fly-by-night operations, and had them all closed, and really began the birth of a modern educational process. So in addition to not having all the data and not having all the knowledge, the cognitive processing load in our field is just growing exponentially. I know as a primary care doc, I'm expected shortly to have familiarity with potentially 100,000 SNPs or gene variants and know what to do if those were to be found in any of my patients. And we simply can't compute in our software, the mind, with all of that. And then Elizabeth McGlynn, of course, a few years back now, but really seminal work showing how we are failing to apply the best evidence when it's known at the point of care. In her assessment of diabetes guideline compliance across the country, in a very credible study, she found only 54.9% of the time were patients receiving recommended care. And you may recall how this hit the headlines for a bit, that getting the right care in this country was not much better than a coin toss. And on top of all this, are we feeling anxious yet? On top of all this, the margins are diminishing in our healthcare delivery systems, big, small, large, medium, etc. And what's happening is, of course, the aging of the population. More patients shift from commercial care into publicly funded Medicare, Medicaid reimbursement. The older patients also have more comorbidities. They're more expensive to care for. And everyone's living longer. So these three principal drivers are driving the margin down, and yet we have more and more to do. Lastly, the sources of waste in American healthcare. These estimates come from the IOM, looking at unnecessary services, excessive admission costs, inefficiency in services delivered, prices that are too high, fraud, and missed prevention opportunities. This is just embarrassing on so many levels that even though we're spending all this money, even though we're still having a great deal of waste and inefficiencies, and even if you were to quibble with $1 billion here or $1 billion there, still unacceptable. Oops. Don't look at the cartoon, please. Oh gosh. Don't look at that cartoon either. So again, compounding the problem, making it such an interesting multifactorial problem, is that access problems for U.S. citizens vary widely across the country. And here, these data show access for the U.S. total on the left, New York, California, Florida, and Texas. And you can see that if you're on the coasts, you're in much better shape. By the way, anyone who wants a copy of the slides, I'm happy to share. But if you're in the middle of the country, Florida or Texas, things just aren't that good in terms of access or follow-through or compliance. Had a medical problem but did not visit the doctor or clinic, did not fill a prescription, and on. So the system is not operating at high fidelity. What we say should happen isn't what is happening. So here's what I don't understand, says Dilbert. You've just asked me to follow a process that's failed 30 times in a row, and you know it. At what point can this no longer be called optimism? And the manager says, when it succeeds. I love it. So what we did, what the country came to, finally, 2008, 2004 rather, everybody remembers the executive order that anointed David Brailer as the first national coordinator of healthcare IT. And it was George Bush, God bless him, who recognized that coordinating these HIT functions across the private sector and across the public sector would be a good thing to do. Meaningful use came along a few years later with the ARA and the high-tech component, and ACA followed that. And in high-tech, of course, came the mandates to install health IT and get paid for doing so, but it was voluntary, at least if you can call that voluntary, and to receive a reward up to a point after which you wouldn't be rewarded if you did not have it in place, you'd be penalized. And the simple thinking in the ONC, David Brailer and Rob Kolodner, who followed him, David Blumenthal, basically the idea was to, get the country online in healthcare IT, capture the data, and begin to make sense with it, advance clinical processes with clinical decision support and population analyses and whatnot, and finally arrive at improved outcomes. If it were just so simple. Oops, again. The good thing is the high-tech stimulus absolutely worked. And it addressed a fundamental problem that I'll have data for in a second. But when a provider system buys healthcare IT, who benefits? Brian, who benefits when your doctor uses an EMR?
The EMR.
Good.
Third-party payer.
The third-party payer, who said it? Yeah. I'll show you some data in a minute. But this was one of the fundamental misalignment of incentives in the marketplace that made the private selling of EMRs, which I was involved in, designing and selling, exceedingly difficult. The leading institutions which had the capital wherewithal to do so would do so. Institutions which owned their own risk would do so, NHS, Kaiser, and the like. But the vast majority of the market for most players was simply not adopting EMR. So this was the stimulus to do so. And you can see from 2009, incentive payments began and adoption proceeded for CPOE, 45%, up to 80% computerized provider order entry for medication orders, 73% for e-prescribing, drug interaction checks, maintenance of problem list, and clinical decision support rules. I mentioned the value assessments. I was involved in the Center for IT Leadership, helped founded this at Partners Healthcare in Boston. And what we would do in sort of the weekends and at night is do stochastic simulation models and evidence syntheses of value for healthcare IT. We found, for example, looking at the value of ambulatory computerized provider order entry, if you build a simulation model, a large cost-benefit model, use literature estimates of value where they are published and accepted, and fill in the gaps with expert opinion, so it's a combination of literature and expert opinion. But in a fairly conservative model, we found that $44 billion could be saved each year if every ambulatory care provider had advanced clinical decision support. So you might ask, what is advanced clinical decision support? It is not just rules and alerts and some care guidelines and the what. It's things like, we modeled this off of the Brigham applications, where there were routines to help dose medicines for neonates, dose medicines for liver failure, dose medicines for renal failure patients, and also how to dose medicines for geriatric populations. So I thought the 44 billion number was big, but then the next study we actually looked at the value of information exchange. If you look at a hospital, a clinic, ambulatory care clinic, there is a wide variety of information exchanges that occurs from that clinic to everybody and their brother. The practice management system, of course, laboratory, orders, referrals, the third-party pharmacy benefit manager, the insurance adjudicator, and whatnot. If all of those transactions, hospital, of course, and other clinics, if all of those first-order transactions were done seamlessly, we defined a 4-level taxonomy for interoperability. The highest level meant full syntactic and semantic interoperability, so you could actually use the information in your PC and make sense of it. The lowest level was, send a fax, not really useful. If we were able to achieve this seamless interoperability across the country, that's worth about $78 billion per year. So interestingly, John Berkmeyer at Dartmouth did an analysis of the value of CPOE across the country. I didn't list it here, it's not a CITL study, but if you take his 30 billion, 44 billion for ambulatory CPOE, and 78 billion for interoperability, you're getting up to 150 billion or so, or about 7.5% of our U.S. national healthcare expenditure. So I won't, again, Coles to Newcastle. I won't try to define biomedical informatics for you all. I love Bill Tierney's quote, though: clinical informatics is the basic science of healthcare. But the way we have to think, I think, about the application of informatics in our healthcare delivery systems and across the land is to recognize the intersection of the core foundational mathematical and computational science dimension, the social science dimension, and the health and life sciences dimension. And you can see how these have their subcomponents and are related, but Phil Payne and others put together this lovely depiction showing how these three spheres intersect. And it's a challenge to be a biomedical informatician, whether one comes out of clinical medicine or computational sciences or library science or what have you, but it can be a team-based sport, game or sport as well. The social science dimension, or the implementation sciences, I think, have been fairly underappreciated until we really got into broad-based, widespread spread adoption. This is Nancy Lorenzi's graphic showing all the activities and governance and implementation details associated with EMR implementation in a clinical setting. And I used this when we wrote the AMIA statement of the board about usability in healthcare IT, just to try to make things more, to show that we needed to make things more simple. The IOM in their Safer Care report described it as in this way, that the intersection of the external environment, people, technology, processes, and organizations all need to be attended to when thinking about successful adoption and use, effective use of these technologies. So I've heard here about the value engineers and people redesigning clinical processes and building new decision support info buttons and the like. And it's a multifactorial kind of problem, and I think this depicts it very well. Chuck Friedman was the guy who said, this is the fundamental theorem. This is the one that I think my mom and dad actually, kind of understood. Brain plus computer is better than brain. And I think that's where we need to go. I like to think of it also in this way. This is the old data, information, knowledge, wisdom pyramid. And I feel medical informatics is oftentimes devoted to the whole spectrum. We increase organization and meaning of data and knowledge as we move towards the top. But I also would like to point out this idea of high velocity medicine so that this transition from data to insight or wisdom can be done as fast as possible. I did it again. So biomedical informatics, I would say, is the field of study which accelerates the transformation of healthcare by accelerating the discovery, use, and evaluation of knowledge with information technology. So translational research, just a short detour. One aspect of translational research, as defined by Rubio, is to think about the processes of applying discoveries generated during research in the laboratory and in preclinical studies to the development of trials and studies in humans, getting that first translation from kind of lab to clinical environments. The second, though, concerns the research focusing on enhancing the adoption of best practices in the community. Cost effectiveness of prevention and treatment strategies is also an important part of translational science. So in the Westfall's paper in JAMA, these are the tried and true definitions of T1, T2, T3. T4 might be considered the community surveillance activities, not depicted here. But again, this is the entire spectrum of work, I think, needs to be supported by the appropriate informatics infrastructure for data management, definitions, semantics, ontologies, interoperability, analysis, and then return of analysis or insight in useful forms to the workflow. So in Phil Payne's article in Medical Informatics and Decision Making, he again shows this translation dimension from basic science to applications, from the computational and information sciences world into the biomedical informatics world, and then finally into IT for use in practice. And just another nice delineation of how data structures and ontologies or algorithms can be defined. Ontologies and cognitive models and methods need to be defined, and we can implement this in an application and technology framework. We will be challenged when the precision medicine really begins to hit in all different ways it will. Certainly we aim conceptually to link the personal genomics, understanding of the genome and a patient's individual variants, to the clinical expression of those variants, and then to treatment options, pharmacogenomics, and tied it together in clinical practice. Again, at the Brigham, they were beginning to sequence, I think, 100,000 patients. Robert Green had a large U01 to do so, and Vanderbilt's sequencing, not the whole genome, but a lot more sequencing is going on. And I think Utah actually is in an extraordinary leadership position with the genetic database or knowledge bank that, I'm getting the name wrong, but what exists here. And it's coming. Yes, I had to put in a Wordle. But there's big data coming from everywhere. Are there any Apple Watches in the room yet? Not yet. But Griffin Weber actually did this graph, and I think it's lovely because it shows so many different dimensions of the data and where the data come from and what types and whether it's structured and whether it's unstructured. This is in JAMA 2014. But you can see on the left the various types of data that might be relevant to our decision making, whether it's the clinical encounter, population analysis, enterprise-wide strategy assessment, or whatnot. Those data can come from personal health records and home treatment and hospitalizations. The key is rather complex. There's several different dimensions of data. Green is pharmacy data, blue is healthcare data, purple is claims data, pink is registry or clinical trial data, and yellow is data outside of the healthcare system. And he makes an assertion about the data quantity with shading. So in the healthcare delivery system, the purple T. In the healthcare center, the claims data, the purple T. The healthcare center, the two vertical bars, and the clinical trials data also wedged in there in pink. But just a great array of data. So what does this mean clinically? Or organizationally and strategically? Clearly we have to understand how to care for patients beyond just the clinical encounter now. We need to think about their care in between clinical encounters and focus more on health maintenance and wellness maintenance as opposed to just rescue care. And these data can help us track what's going on, some of these data, in between clinic visits or hospitalizations and the like. It came up today, actually. I can't remember with whom I was chatting, but Steve Schroeder and others reported on the determinants of health and their contribution to premature death. And it's always sobering to look at the healthcare wedge here and realize that it's only 10% determinant. The others, environmental exposure, social circumstances, genetics, and the behavioral stuff is incredibly important. And that's why, going back to Griffin Weber's slide, we need to think about how to get those behavioral, or environmental, or other data and learn what to do with them to care for populations in probably a whole new way. And by the way, 4% of the healthcare dollar in 2007 was being spent on prevention and public health, and the rest of it on our acute care system. So the Larry Green and his colleagues wrote a paper a bit ago on the ecology of medical care. And I loved this graph the very first time I saw it and ever since. It shows how for 1,000 patients, 750 adults might report a symptom or illness or injury, 250 consult a physician, 9 adult patients are admitted, 5 adult patients are referred to another physician, and 1 adult patient ends up in the AMC. Now, Larry Green went back to this data and updated it in this analysis, which shows perhaps even more differentiation of patient outcomes or where they go due to changes in the healthcare environment. 1,000 persons again, 800 with symptoms, 327 consider seeking medical care, 217 visit a physician's office, 113 in a primary care office, etc. 8 are hospitalized, 1 is hospitalized in an AMC. So how do we take this picture and begin to turn healthcare on its head? How many of you have heard about flipping the classroom? Yeah. You know, the idea for the kids that really the classroom is where you're not just lectured at, well, like this, I'm sorry. You're actually, hopefully you've prepared the night before, read all the materials, done all the problems, and come and have a conversation with the teacher and your colleagues that apparently is, you know, much more useful from a learner's perspective. And I think Christine Sinsky in Iowa has had very similar ideas, and she's relating them to the AMA. So I think we're going to hear more about this approach of flipping the clinical encounter. But I drew in the line here, 58% of them have a smartphone. So the question is, if we are already wiring the patients, what can we use in the smartphone? What's the right kind of app experience for the patient to either stay above the line, manage the symptom or health and wellness more themselves, or if going below the line, what data can we bring from their home environment, wherever they are, the longitudinal picture before they hit the hospital or the clinic? So a guy named Daniel Kraft and some others put together this graph. This shows the increasing cost going from healthy and low risk patients to at risk and high risk and eventually chronic disease to the more costly acute disease, chronic disease progression, and finally end of life care. Everyone knows the basic heuristic. 20% of healthcare costs are generated by 80% of, 20% of the population generates 80% of the costs. So strategically, how do we move the curve, which seems to grow inexorably up and to the right, how do we move it to the left? What are the components of IT-enabled care redesign that will make sense? Is it the home ICU? Is it home birthing? Is it rehabilitation at home after major surgery? What have you? So in care redesign, I think, you know, lots of ideas are being tested across the country. I think we do not yet know truly how to redesign a lot of things. Certainly, evidence-based care bundles, the idea of making sure that an order set and its attendant decision support and all the related clinical flow and processes are working in concert when a patient comes in for heart valve replacement, for example. We did studies at Vanderbilt on this very idea, with an exception from Medicare, got a capitated fee, and implemented this valve bundle for a mitral valve replacement, and actually were able to demonstrate cost savings. It was critically important to get the decision support right, the process map right, and there were 17 steps where critical checkpoints were assessed. The second thing I think we talked a bit about at lunch is the idea of standardizing the clinical outpatient model, the clinical outpatient encounter model. Right now, different domains of medicine see patients in the outpatient environment in widely divergent ways. Any dermatologists in the room? I know there's one radiologist. Internal medicine sort of has its prototypical approach, and in dermatology it's completely different. Examine the skin first, maybe take a history, patient's out. We talk to the patient first, do an examination maybe, and the patient's out. All those kinds of differences are important. But what it leads to, if you can actually standardize these 6 or 7 steps from intake and vitalizing, rooming, and the clinical encounter with a physician or clinician, and then disposition, orders, and follow-up, it allows us to keep track of what's going on, obviously, and allows the EMR development to focus on the appropriate standardized model. Beyond the one-on-one encounter, though, there's a lot of effort, of course, looking at population health and population management. So here, I think the trick is going to be how to arrive at the algorithms which appropriately differentiate high, medium, and low utilization patients, and have protocols established so if you have a low or medium utilization patient, try to manage them on texts or voicemail or interactive voice response data gathering or an app wherein they can plug in their daily weights or actually monitor the home environment, the home weight scale and whatnot, and gather some of these data automatically. We're doing some experiments now at Vanderbilt looking at exactly this idea. A Medicare demonstration project was awarded, and the goal was to take 1% out of care costs for diabetes using both the population health management tools, a care manager, a dashboard, and a set of algorithms to differentiate, segment the population, and then protocols to apply to each segment appropriately. And combine that with this outreach technology for phone, text, IVR, data gathering, or an app. Lots of work going on in hospital in the team-based care arena as well. How do we make sure that all members of a care team are in sync with what's going on with the patient, care plans, and sign-out type of tools and whatnot. But also the notion of a navigator. Certainly has come up, well, personally in my case, my mom ended up retiring in Florida with her several morbid conditions, and she was lucky enough to find a lady who would pay all the bills and sort of help with the clinic visits, and not really a clinician, but someone who could help navigate the process. What I would have loved would have been for that navigator to have access to her record, if you will, in a patient portal, with permission, of course, to then help the doctor, patient, or the care team and navigator communication proceed. So the point, I think, here is we need to think radically, actually, about improving not only the efficiencies of the one-to-one clinical encounter and streamlining that like McDonald's, clinic efficiencies beyond the one-on-one encounter, hospital efficiencies as we think about throughput and the production function of healthcare in a hospital. Where are the resources? Where are the people? What is the scheduling availability? And where are the physicians? All that kind of stuff. And then beyond that, system and IDN efficiency. If we're actually sharing patients across an IDN, I want to be very clear on what's happening to the patient who might be coming in for referral, or similarly, analogously, send an information package to the receiving hospital saying, here's what's coming, and ideally have a patient care plan object that could persist with the traveling of the patient from site to site, be updated by the activities at the site, and then follow the patient to referral or to home or to follow-up, what have you. This also will apply, though, not only to those settings where it's our IDN and our brethren or affiliates within the IDN, but it will apply also when patients in their normal and routine course of care go to different institutions and care settings for their. And hopefully, attention to these multiple levels of efficiency, the information deficiency, the knowledge deficiency, impacting on care processes and standardizing care flow, we can improve patient safety, reduce harm, improve the quality of care, and minimize error and waste. And everyone is in the same boat, discovering themselves the ways to do this best in their own environments. And as we assume increased risk, it should pay off. So what might be some tactics to consider? I apologize for this somewhat complicated slide, but Peter Emby and Phil Payne in another article, oh no, same one, looked at the attributes of organizations who had been successful to some degree in addressing this need of the translational science requirement, if you will. They examined 3 institutions on 5 axes: a leadership model, funding model, research to production translation, training programs, and the bioinformatics home. And Case 1, a mid-sized public university, had a coordinated leadership model like you have here, academic and health system support, comprehensive research support, both professional and research-oriented training programs, and an academic department of biomedical informatics. I think actually we will not get this whole translation to proceed across the country until we have a Department of Biomedical Informatics in every AMC in the country, because these are the folks who can help do the data, the knowledge, the semantics, and the analyses and the like. Case 2, a large public university, integrated leadership model, academic and health system support, minimal support for research. Training programs were research-oriented, and there was a center, not a department. And the last, a large private university, integrated leadership model, academic and health system support, comprehensive research support, good training, and also an academic department. Beyond organization, I think the other thing to think about is incentives. What are the behavioral economics, and I meant that on purpose, that will actually cause behavior change among physicians and nurses, and after all, even patients as well? Craig Milford and Tim Ferriss at the Mass General were responsible for all kinds of interventions to improve care in the Massachusetts Physicians Organization. They needed to reduce the cost trend. They were building new contracts, acquiring new contracts with increased risk. They applied some changes to the organizational structure and built out a population management infrastructure, enhanced care and a PCMH and coordination for high-risk patients, just as I was describing, and enhanced access to specialty services, changes to the organizational incentives, new local incentives, and network affiliations to balance or optimize care across the regional community network. And the kinds of things they were looking at, I think this is kind of clever because it divides things into access to care interventions, design of care interventions, and measurement, and separates those which apply to longitudinal care and episodic care, and even so delineates primary care, specialty care, hospital care, and all kinds of things, you know, high-risk care management, readmission assessments, standard processes for priority conditions, handoff, EHR with decision support in all settings, clinical quality metrics, patient experience and satisfaction metrics. And the good thing is it worked. It wasn't because of these various informatics interventions on the right-hand side, though. All stuff we know and love, much of it built here, researched here, and whatnot. But it had to be tied to the incentive program and the business case, fundamentally the value proposition in the doctor's mind. Oops. In Circulation, Peter Emby and others described their knowledge translation stack, if you will. Again, thinking at kind of macro architectural levels. How do we build upon the healthcare practices and policies which generate, influence, and or generate data gathering into a wide variety of data resources, transactional data resources, which can then inform, create infomarts to inform specific sets of analyses, and then support or be leveraged by the decision support systems across the institution. At Vanderbilt, the way our stack more or less, the architecture more or less looks like is similar to a degree. On the clinical enterprise side on the left, many source systems for transactional data, and in the middle, the informatics methods development, including lots of different skills and expertise in NLP, pattern recognition, phenotyping, etc. Creation of a de-identified database and identified database. This is the research derivative and the synthetic derivative, respectively. And importantly, attached to the SD, the BioView tissue repository. So if one wished to correlate genotypic and phenotypic data, it can be done fairly readily. And support the research enterprise with REDCap and many other tools that identify patients eligible for protocols and whatnot and can help recruit. Another one that's gotten a fair amount of attention is the STRIDE environment at Stanford. Henry Lowe, the Stanford Translational Research Integrated Database environment. Very much the same idea at the highest level. Take data from the transactional environments, SUMC clinical data, adult EHR, the pediatric EHR, create a clinical data warehouse, and derive cohorts from the warehouse and subject them, when permitted, to analyses in a wide variety of ways. One of the examples from STRIDE that caught a lot of attention, many of you may have seen the Frankovitch Report in the New England Journal of 2011. A 13-year-old with lupus was admitted to hospital, and they had to make a coagulation, anticoagulation decision. There was some complexity to the case. They looked up in the EMR, EPIC, what was the prior experience with similar cases, and were able, basically in 24 hours, to develop a set of coefficients describing the risk of anticoagulation or no coagulation, and informed their decision. Although many other groups have highlighted the secondary use of EMR data for clinical research, we have now seen how the same approach can be used to guide real-time clinical decisions. I said this to a couple people today. As a one-time epidemiologist, in a way, I'd love to see this happening for each and every clinic visit. That I can do the what-if analyses, what if I treat with this drug versus this drug, compared to the most recent 1,000 patients with a similar index decision net in Utah, and see which makes the most sense. Okay. Now, it gets really interesting when we begin to think about how to use our implemented HIT with appropriate architectures, as I've just flown by, but how do we make them then part of a national resource for investigation and analysis? So Ken Mandel and Isaac Hahn up in Boston wrote a paper in Nature Biotechnology on Federalist principles for data sharing. But it's really fairly elegant. If one can build these edge servers from your data environment that can serve the needs of the network and receive the request or generate a request and go out across linked networks to gather these data, why not have our investigations benefit from the entire experience that are appropriate? But I'm moving towards the final punchline. So it is all about the data. It's all about connectivity and interoperability. It's all about continuous monitoring and engagement of patients. But it's also going to be about the knowledge base and how credible is our knowledge base, and how do we build and refine and maintain these knowledge bases that are used will be used in every dimension of clinical care. The American Society for Cancer Oncology, I think that's ASCO, wrote a blueprint document describing how certainly we've seen the progression of disease into a much more differentiated understanding of, for example, lung adenocarcinoma. Actually, lung adenocarcinoma may be any number of different subtypes of disease, each warranting its own clinical approach. So how do we keep track of the hundreds and hundreds of thousands of potentially important emerging gene variants and subtypes of disease? ASCO believes there should be creation of a central knowledge base. It's informed by research updates and informs researchers' knowledge, takes patient knowledge and patient data and experience to update the knowledge base, provides provider knowledge and provider data, provides decision support, and then provides provider data into a thing which can help keep track of it all, knowledge management. This is the last of the intro slides. No, I'm just kidding. When I think about that kind of vision from ASCO, or the vision all of us have, I think, in informatics to inform decisions, improve population outcomes, and the like, we really need to address every component of this graphic, from understanding the cognitive and behavioral foundations, the reasoning foundations, behavioral models. Charlene Weir, you may remember seeing this picture before in our SHARP proposal. Create from that understanding patient-centered data abstractions and do the knowledge engineering to create patient data objects. Implement reference standards in architecture, like Ken Kawamoto has done exceedingly well in the HL7 context, and then measure the effective use of patient cognitive support in health IT. And I borrow, if you will, from the bioinformatics world, because really it's transcription, translation, expression, and we need to understand those kinds of relationships. But there's feedback loops for every single piece of it and every single part of it. And to my mind, this then is truly a learning healthcare system. It's a little more detailed than we've been talking about mostly to date. So I'll close just with a quick highlight of an example of a system which attempted to do this centralized knowledge management, deliver web services, and influence care remotely. So why is this interesting? Suppose the University of Utah creates the best knowledge base for gene variants given its extraordinary genetic database and whatnot. It could create an AI program that would represent this knowledge. And the performance of these things depend more on the explicit of this knowledge rather than ingenious computational procedures. Notice that's a bit of a distinction from what IBM Watson is all about. Just to keep the humility index well-oiled or high, I was doing BeliefNet research in fellowship. My wife found this cartoon for me. And it says, I typed in your description of the symptoms. The computer says you have Dutch elm disease. We have a little bit of work to do on inference. But the goal is, no matter which of the inferential methods are being used, can we take a knowledge base developed at one place and make it available or accessible to a inference environment? And I think that's a dream. I think it's possible that we could take large bodies of knowledge and have them used in different inference engines or different inference systems. Certainly some work has been done in this area. But I think the simpler thing to do actually is going to be to create a web service or a knowledge service in the sky, cloud-based CDS, and with that then allow centralization of the problem and distribution of the benefit of clinical decision support and analysis. This is a very geeky slide showing the evolution of various knowledge representation formalisms, and it's not even complete. Peter Elkin and others created this way back in 2000. But it shows just the wide variety of methods that have been pursued, and each has had their good parts and their bad parts. Fundamentally, we need to take evidence and experience, form guidelines that are agreed upon, represent that in a knowledge format that's acceptable, maybe convert it into a shareable knowledge format as well, but make sure that we can present it in an executable format so the best knowledge at Utah might be available to the folks in Montana or what have you. I will skip through this. The current paper-based approach is very labor-intensive, thus many clicks. The knowledge artifact is a better idea if you can get a representation that people can do import-export with, and there's been work by some of the vendors to do that. Medicalogic did do that. But better is to actually do all the knowledge engineering kind of in the factory and serve it up as a web service to a remote EMR or EHR that is complying with the expectations, providing the patient data object in the form that's requested and receiving decision support in the form that's useful. So we had many goals in the CDS consortium, but the best part, lots of collaborators across the country from knowledge vendors, HIT vendors, academicians, and many others. And it was terrific in a pre-competitive way to get at some of these very thorny problems. We created a knowledge repository and a viewer. This is still available out there today. You can go and search for different conditions or different settings of care by different content types, whether it's a rule, an info button, an order set, and by different specialties. And this builds upon the knowledge management portal that was created at Partners, because we had piles of stuff that no one was really paying attention to and managing in a thoughtful or rigorous way. Lastly, the architecture for this inference from afar, a data object, CCD, partner Zs, or smart architecture stuff, VMR, or an OpenEHR message is sent in to our environment, the Enterprise Clinical Rule Service, and then it is sent to services which can translate it if need be or normalize if need be, and create the patient data object which is sent back to the rule execution server, iLog in this case, which ran all the rules pertaining to this patient, made a recommendation, and sent that back to the receiving EMR. Interestingly, the goal here was simply, non-inferiority. In this list of reminders under the red tab, you can see those that are generated by the EMR itself in the partner's EMR, as well as those generated by the CDS Consortium cloud-based service, and the idea is to not be able to tell the difference. So partners did it, and Regenstrief did it, Epic, NextGen, and GE did it as well, and we had demos running across the country, and there's a lot of papers if anyone's interested. And this actually dovetailed nicely with the advanced CDS project that Rand and Brigham and Ken and others were deeply involved in as well. And I think this is now, Ken's taking this in the open CDS and extending these ideas dramatically. So in the end, my goal would be to operate the mouse. But I hope we can actually have this idea of a national healthcare network or interoperability and exchange of information. But I'd love to have all the patient data go with all the knowledge to wherever decision making is occurring. Thank you for your attention. There's time for maybe half a question. No. Please.
I hesitate to ask one slide.
Sure.
I got a lot of practice. So you talked a little bit about behavioral economics. I'm just interested if you're basing this vision on a national network of national data, what's the incentive for a local individual institution to invest? Or what's the advantage or what's the space that an individual institution would invest in this type of capability?
It really starts at the local level. If you're not incentivized at the local level to share data in the construct of an ACO or some other kind of risk-sharing program, then yep, you probably are not interested in sharing data. But once you're sharing risk in any way in today's world, I think that would be incentive enough, because you actually will get you will receive knowledge and data, hopefully, that you didn't have already, and it will improve the care you provide for your patient. Obviously, in the limit, one would like to say, that we are two things. One, we're not paid on, what we know versus what we don't know. Everyone should have a common knowledge base, and we're paid on execution and high-quality services. But also that, we're all sharing risk, and I'll leave it at that. Whether it's a single payer or some other form of healthcare payment reform, if we're all sharing risk, then you'll be incented. Does that make sense? Please. Do I think what is a viable?
Do you think that's a viable incentive for interoperability on a national scale? That's pretty important.
Yeah, no, it's a good question. Certainly the technical issues of interoperability have to be wrestled down to the ground, and FHIR and Smart on FHIR, those interesting ideas coming up there. But as an incentive, I don't think we'll see this seamless national exchange anytime soon. But I would hope within the Vanderbilt Health Affiliates Network, 50 hospitals, 7 systems in 7 states, that there would be seamless data exchange, because we're all sharing these patients under risk. And the same at every other institution doing that. And once you get there, then the next step becomes easier. Please.
So what do you think the patient's role is with this? I mean, you showed the determinants of health where 10% is the clinical information, the genetic predispositions of that you have, whereas 15 and 40% that are related to characteristics of the patient that are probably not going to be information that's going to be shared, because this information exchange is still just about the clinical information. What is the patient's role, and what is the role of the patient information?
Yeah, great question, Adam. I apologize. I got momentarily distracted, but let me see if I got it. You know, there's a couple of thoughts. One, you know, the patient-controlled PHR, the theses of Boston Children's and Ken Mandel and Kahani and others, would suggest that the patient actually has to give permission to whomever is going to view the data. Now, I'm not sure I would be very interested in doing that at any more granular detail than, yes, every clinician in an accredited institution can have everything. I really don't care. You know, which patient data is the second question. Do the patients have sufficient understanding to segment data? Of course, in clinical practice, patients withhold data all the time. You know, whether it's the drug-seeking behavior. I'm not aware of the codeine prescription last week at a different institution. I don't mean to be pejorative, but, you know, or whatever. Go on.
So I think this is the point where the distraction happened. I'm asking more, there's information the patient has that the doctors don't. Not the patient actually transferring information, being the translation mechanism from clinical data to clinical data. They're probably not skilled, they're not trained. But there's information that the patients have that actually influence their health determinants that the providers need to know. Where does that information fit? Sorry.
So weight, for example, patient weight at home, stuff like that. I mean, very.
Yeah, or patients' behaviors, or patient perceptions of change.
Yeah. Good question. I don't know, but I think as we get into the wearables and quantified self, a lot of it's going to be generated by. Some of it will be generated by that, activities and behavior and whatnot, but it'll take a while. Please.
So given that the idea is that the decision support is going to perform better the bigger than all of these, when someone shares information to ask for a recommendation, do you get to keep that information, or do you have to just hand it back without keeping it up?
You keep it. Yeah. I mean, it becomes, if you act on it, whether you act on it or not, it's a message that was sent to you. It doesn't have to be kept in the medical record per se, unless you act on it. Then you'd want to have the complete legal trail of why you were doing what you were doing. Well, sure. But I think the vision of this knowledge repository in the sky is, if you have the best, chemotherapeutic protocols for, all the lung cancers or what have you, those are shared. And if you're looking for the best chemotherapeutic protocols for, pancreatic tumor or something like that, if you're not so good on that, then you download what you need. So it's a library, sort of open knowledge sharing platform. Correct. Next question. Those who are interested, a couple things, and not meaning to be self-serving, but the usability task force report AMIA published last summer has a bunch of recommendations that I think would actually be helpful. What if we had a common style guide for the UI for, the 8 things the ONC thinks are important that we should all be doing usability testing on? That'd be kind of cool. I certainly don't need to have a manual to figure out how to use a national rental car versus a Hertz rental car when I switch rental cars, but the poor docs today, may round on Epic in the morning and practice all day on Cerner, and then if they go to a third hospital, round on something else, that's a nightmare. So the usability guide and those kinds of recommendations. But the other thing I would suggest is I think the whole paradigm is going to shift as we get more sophisticated with voice and NLP and sort of the cognitive ability to follow and track what a conversation is about. And if you haven't seen it, I would suggest you look up the Harvard Risk Management Foundation EMR of the Future. A bunch of ideas were put together into a very, futuristic video, very compelling. It's out there. It's kind of science fiction, but very, very interesting.